house. And so
No
there's
worries.
that.
Yeah, we completely understand. All right. Hello, everyone. Welcome back to another virtual shadowing session at Hearts for Health. This is a new one on a Saturday, but we're very excited for it. It's going to be with Dr. Sims, who is a board-certified OB-GYN. She's also the Associate Program Director for Wellness, Diversity, Equity, and Inclusion at the University of Mississippi Medical Center. For those who might be new to virtual shadowing, for any new participants we want to have just a few reminders and a few notes for you. Towards the end of the session today, we'll have a Q&A. So if you look at that chat box feature that you have, you can write in and type in any questions you have. We'll cover those at the very end of today's session. For those who want to stay updated with future shadowing sessions, we have these on a Monday and Thursday basis usually. Sometimes we might have sessions outside of that, but we'll keep you posted via our listserv and our Instagram page. You can subscribe to our listserv and get added on by subscribing to the subscription form at the bottom of each page on our website, or just email us with your name and email address at shadowing.h4h@gmail.com. So that's the number 4. And those are just the reminders for anyone else who has any questions outside of that. Feel free to email us and we can get back to you. But other than that, Dr. Sims, feel free to take it away.
Okay. Hi, everybody. I'm so excited that you are here to join us for your shadowing session. Just so you know, I am on call. So my pager may go off. Everything is live. We do have a C-section coming up and then probably another C-section after that. I'm not sure how quickly they'll roll, but we'll do as much as we can before everything turns into a crazy house here. So today I wanted to talk to you about 1, the road to obstetrics and gynecology, and then 2, we're gonna do a couple of cases. And then after that, if there's time, I'll walk you around the hospital, let you see the residents and nurses, let you see the operating rooms, things like that. So we'll talk about what is an OB-GYN, the practice settings that you could potentially work in, subspecialties, why I chose OB-GYN, and of course some cases. So an obstetrician gynecologist is a practitioner of young ladies and women. There is the obstetric side, so you do your prenatal counseling, which is really kind of more of a GYN because of course the person is not pregnant, but you can do that as a maternal fetal medicine specialist too if the person is high risk. You care during your pregnancies, deliveries, and the postpartum state. For the gynecology part, you do your wellness visits, which is people will call like your annual or your pap smear visit. And then during those, it's like your pap smears, clinical breast exams, mammograms, age appropriate screenings. And then of course you want to include like STI screening, talk about nutrition and exercise, screening for depression, contraception management, and menstrual cycle management. And the reason why I wanted to make sure I mention that is that just because someone has an annual and people think, oh, you just go and you get a pap smear in a mammogram or a pap smear in a breast exam, you actually have to consider the entire person. And so that's why I said, okay, you know, your nutrition, your exercise, because sometimes as an OB-GYN, we're the only doctor that a woman may see for years and years. Practice settings, hospital. So we're here at a hospital right now. There are hospitalists. Of course, this will be like a person that are here for operations, deliveries, admissions, and then hospitals like I'm doing right now. Right now, I'm just here on a call shift, so I could be considered like a hospitalist because I'm covering just the hospital and not the clinic right now. And then you have your clinic setting. There's a private practice. There's federally qualified health centers, which I work at. And then there's like the VA system. There's universities. There's multi-specialty groups. So there's lots of clinic type settings that you can work in. And then there's a combination. You can do where you practice in the clinic, and then so actually I do multiple. So I'm mainly working at a federally qualified health center, but I also have hospital privileges here at the University of Mississippi Medical Center. So this is a university, and so I have like my teaching and stuff like that while I'm here. Then you have your subspecialties of obstetrics. This is maternal fetal medicine. So they care for women who are high risk themselves, and they also care for patients who have fetal anomalies, meaning birth defects, things like that, that they have seen while the person is pregnant. In order to become a maternal fetal medicine specialist, you have to do a 3-year fellowship. Then you have your subspecialties on the GYN side. And so there's pediatric gynecology. And so this is a person that cares for young girls in general. So I'll tell you this, I do care for lots of young ladies while they're, in the non-pregnant state as well. So you don't necessarily have to be a pediatric gynecologist. It's just that they actually have a 2-year fellowship where they do training specific to uterine anomalies and vaginal anomalies and things like that, where they can repair those. So they mainly come to us at that age for menstrual cycle control or hygiene. And let me tell you, we're not talking about just regular like body odor hygiene. Menstrual cycle hygiene is, say for instance, you have a person who's wheelchair bound and it's difficult to manage like their bladder, difficult to manage like carrying them in, things like that. So you may actually put them on some type of contraception in order to stop their periods or make them really, really light, so that their caregiver has a better time taking care of them and keeping them clean. So that's what menstrual cycle hygiene is. And then the uterine anomalies, which I mentioned, and then again, it's a 2-year fellowship. Minimally invasive surgeries. So basically this person goes to a 2-year fellowship and they learn more about the things that we have already done during residency, and they basically hone in on their skill set with like robotic surgeries and with a straight stick, which basically means laparoscopy, where you stand next to the patient and perform your surgery. Subspecialties, again, urogynecology. So this is a pelvic floor specialist. So pelvic floor, what does that mean? They manage the lower urinary system. And so say, for instance, someone's uterus has dropped to where you can see the cervix outside the vagina, or it's like dropped low in where you can see it just like right on the inside of the vagina, or like their bladders drop or their rectums drop. Basically, you can perform almost like plastic surgery of the vagina and make it all look nice again, tack everything up. And they also deal with pelvic pain and things like that. And this is a 4-year fellowship. Gynecologic oncology. This is a person that deals with cancers of the female reproductive tract. And so this is your cervix cancers, your ovarian cancers, your uterine cancers. And so they manage their cancer patients, and they also can do chemotherapy. That's a 4-year fellowship. And let me tell you, during that fellowship, they become master surgeons. Like our GYN oncologists here, they're the bomb.com. You call them when anything pops off because they can handle it. So why did I choose OBGYN, and why do I feel like a lot of people do? I love the mix. I don't want to be in clinic all day, every day, and I don't want to be in the hospital all day, every day. And so it has a nice mix of the different practice settings. Every day is different for me. Like my plan is to be in the clinic Monday, Tuesday, Wednesday, and Friday, and then my hospital day is Thursday. But I could get called from clinic at any point for a delivery. Also from home in the middle of the night, 2 and 3 o'clock in the morning, or on the weekends. And so that's what I love. Every day is different. And then I love, for myself, just taking care of women. I was a cheerleading coach for 10 years. And I think it all kind of stemmed from there because I was always mentoring and helping young ladies. And so for me, wanting to be a physician, it just kind of like made sense to just continue doing what I had been doing by working with women and young ladies. And I love life. I love bringing life into this world. It's a beautiful thing. I love being there for precious moments with ladies. So let's go to our cases. I don't know if we need to stop here to see if there were any questions, or we'll just answer them at the end.
Yeah, we can save them for the end. Right now, there's not many.
Okay, sounds good. So we have a 21-year-old lady who presents to the emergency room. She has lower abdominal pain. And so I made this because in my mind, we were all going to be kind of on Zoom, but so I had what questions you have for them for this patient. I don't know if you want to just see if they're going to ask any questions, like what kind of questions, put it in the chat, what kind of questions you would ask this patient.
If you want to, just because there's a little delay with the live stream, if you want to go through each case and then just ask these questions for the students,
Sure.
and then that will give enough time for everyone to have their responses come in.
Okay. So normally what we would ask for this patient is, number one, is there any chance that you could be pregnant? Where is your pain? How long has it been going on? Last menstrual period, things like that. Any nausea, vomiting, things like that. And then of course we, when we form our differential diagnosis, the differential diagnosis is when you come up with what all it could be. So you don't want to hone in on one topic. And the reason why I put those there is because, of course, this is an OB and GYN presentation, but you also have to keep in mind the GI system and the GU system. So the GI is like your intestinal system, and the GU system is like your urinary system. And so, like GU would be like, a urinary tract infection, or GI would be like, appendicitis, things like that. And so keeping those things at the forefront so that you don't miss something major for a patient. Did anybody think of any other questions that they may have had for this patient? Did you see anything in the chat?
No, none popped up.
Okay. All right. So the physical exam that I would consider for this patient is, of course, a pelvic exam, and then an abdominal exam. So you want to do abdominal and pelvic on this patient. And then the types of labs. What kind of labs would you think about doing for this patient so that you can help you finalize your diagnosis? So her vital signs are there. Blood pressure is fine. Heart rate is up a little bit. Respiratory rate is fine. Her oxygen saturation is fine too. She has left lower abdominal pain. So of course that's away from the appendix. So it kind of takes you away from that, but you still don't want to rule it completely out. Her blood count is low, so she's anemic, and her pregnancy test is positive. You never want to forget to do a pregnancy test on a lady that says she has abdominal pain, because it would be horrible as a physician to miss a pregnancy, wouldn't it? Like, it would be horrible. And then at this point, you do a sonogram. So on her sonogram, there was no pregnancy in the uterus, there was blood in the pelvis, and then there was a mass near the left ovary. So that kind of accounts for her left lower abdominal pain. And then with her sonogram, so these are transvaginal, meaning you put it in through the vagina so that you can see the reproductive system that way. And so there was probe tenderness, and that's very significant because it lets us know that there could potentially be some type of pathology. So her diagnosis is a ruptured ectopic pregnancy. Now I'll go back. The things that led to that is no pregnancy in the uterus, pregnancy test is positive, and there's blood in the pelvis. So even if you don't see a mass, it's a ruptured ectopic pregnancy until proven otherwise. So plans for her would be to the operating room for a diagnostic laparoscopy. And then of course, you would perform a unilateral salpingectomy, and it's urgent. When someone is ruptured, they could potentially suffer from demise, or they could pass away if you don't get them there quick enough, because they'll bleed out. You already saw that she was anemic. Then of course you monitor blood loss and blood counts. You'll get another possible blood transfusion, but you'll get another blood count so you can make sure that she's stable in the postoperative state. These are just a couple of pictures. Can you all see my cursor?
Yeah, we can.
Okay, so this right here is the uterus. And as you can see, there's no baby in there. And this right here is a bunch of blood clot outside of the uterus. And then here's another picture of the uterus. This is like one of the best pictures that we like to see. Here is the cervix and the lining of the uterus here. So typically here is where you would actually see the pregnancy. And then there's a bunch of blood behind the uterus. So that's ectopic pregnancy that is ruptured until proven otherwise. When you see the blood and no pregnancy in the uterus. Here is the ultrasound, the laparoscopy picture of it. So you're inside, you go in through the belly button, and boom, there it is. There's blood in the pelvis, and then you can see right here, this is the ectopic pregnancy. Ectopic means pregnancy outside of the uterus. They can be in the abdomen, they can be in the tubes most of the time. That's most of the time where they are. This right here is a picture of a ruptured ectopic pregnancy. So y'all see the difference. Here on ultrasound, we would just see no pregnancy in the uterus here, and then we would see a mass, or we would see, we would have probe tenderness. Here is kind of like that ultrasound picture that we had. So the uterus, and then a whole bunch of blood, and then here's that mass inside the tube. All right, here is case number 2. This is a 35-year-old lady. She is 30 weeks and 3 days pregnant. So this is G1P0, meaning she's been pregnant 1 time, not had any children. And then her prenatal complications, she's advanced maternal age, so 35 and up is considered advanced maternal age. I don't know why they think that, because people want to get their careers first. Anyway, gestational hypertension, meaning she's got high blood pressure only in pregnancy, not outside of pregnancy. So she came to clinic. She had a routine visit. She said, I just don't feel right today. I don't know what the heck is going on, but I just don't feel right. Let me tell y'all something. When a pregnant person says to me, I don't feel right, and they can't describe it, I'm always like, what's her blood pressure? Because that's like a bomb waiting to happen. Like, I want to know what her blood pressure is, because some people don't feel preeclampsia, or sometimes they just don't feel right when they have preeclampsia. And preeclampsia is a more severe elevated blood pressure issue with pregnancy, where the blood pressures are higher, and you can actually end up having neurological symptoms like blurred vision. You can have severe headaches. You can even have a stroke from it. You can have seizures. You can have liver damage, kidney damage. I mean, you can have fluid on your lungs. You can end up having like a cardiomyopathy. So it's like a severe, like it's a serious thing. And where I work in Mississippi, we see it every day. Like right now on our board, there are multiple patients that are actually postpartum from preeclampsia. And so it's like we deal with it every day, but not all hospitals have to deal with the very, very sick patients like that. So the type of questions that I want to ask, I kind of went through those. I wanted to know, okay, what's her blood pressure? Like, are you having any nausea, any vomiting? Is your baby moving? You want to know just kind of a whole picture. And then what exam do you want to perform? So I want to, 1, get heart tones. I want to look at her extremities. I want to see if she's edematous. Look at her eyes. Sometimes with preeclampsia, people have swelling around their eyes. It's called periorbital edema. I actually had that. Listen to the lungs, because you want to know if there is concern for pulmonary edema. And then check her cervix. I've had people say, I don't feel right, and then they're in labor. And so check a cervix if they're, in a good position, blood pressure's fine, whatever. So you want to check the cervix. So here are her vital signs. This is considered a severe range blood pressure. Anything that's greater than 160 on the top or 110 on the bottom, it doesn't have to be both, is considered a severe range blood pressure that basically you have to immediately treat. And you may see a blood pressure like this for someone who is not pregnant, and people just say, oh, okay, just take your medicine when you get home. Yeah, that's fine. But in pregnancy, hex to the no. Like, you have to manage it right away. And the reason why I say that is because the person can have a seizure, the person can have a stroke, the person can have a placental abruption, meaning the placenta separates from the wall of the uterus, and it can cause death of the baby and the mom. And so you have to get the blood pressures down a lot more acutely for a pregnant person. The replete blood pressure is even higher, sweet Lord. And then the heart rate is 109. You'll see a little bit elevated heart rate in pregnant women just because of the physiology of pregnancy. Sorry, I'm just watching these patients. There's some scary patients on the board right now. Not necessarily scary, but patients we're watching very closely. Lungs are clear. She appears fatigued and sweaty. Her abdomen is soft, non-tender. The reason why you want to know if it's non-tender and it's soft is because a sign of a placental abruption is a rigid abdomen. Edema in her lower extremities, her hands, and around the eyes. The baby's heart tones are 140s, and she's reporting good fetal movement. So what are your differentials? I say pre-eclampsia until proven otherwise. There are some other conditions that can cause these things, like, for instance, swelling in the hands and feet. That could just be, regular pregnancy stuff, but you have to consider, the entire picture here. So I said that part there. Basically, you need to get the patient to the hospital and get some labs as soon as possible. And the reason why I say that is because you want to know, okay, is she having any issues with her liver right now? Is she having any issues with her kidneys right now? And so the labs that we get would help us to identify that. And there's even conditions that go even further beyond preeclampsia, and it's called HELP syndrome, when the person has elevated liver enzymes and low platelets. And then, of course, you want to put her on the fetal monitor in the meantime. Watch her closely, watch her baby closely. So while the patient is waiting to leave the clinic, she falls to the floor and she starts shaking. So what do you do? So basically, this patient is now having a seizure, because remember I said the person can have a seizure from those elevated blood pressures. So basically, you want to turn this patient in a position where she's not going to hit her abdomen or her head. And then your new diagnosis is now eclampsia. So you have your pre-eclampsia, and then once the person has a seizure, it's called eclampsia. So you take that pre off of there. Lay the patient flat, make sure she doesn't hit her head or her abdomen, like we said. Call the ambulance. Sorry, I'm saying these things before because normally I would look at the chat and see what people are saying, and I'm just kind of answering them as I go. Call the ambulance for a quick transport. If there are some medications in your clinic, which we actually had this happen in my clinic one time, and at that point I was like, we got to have some Ativan or some magnesium in this clinic. And every once in a while, I'll go back over with the nurses like, hey, does everybody know where the mag is? Does everybody know what it is? And does everybody know the doses? Does everybody know? Because the dose for this magnesium is actually higher than what they're supposed to inject in a muscle site. But because it's an emergency, got to make sure everybody knows you can do it. It's supposed to happen because we have to take care of that patient in that type of manner. And so you inject both hips with 5 milligrams of magnesium. So just a little bit about preeclampsia, elevated blood pressures in pregnancy, in addition to one or several of all of these. So protein in the urine, visual changes, abnormal liver enzymes, fluid on the lungs, abnormal kidney function. And then it's one of the leading causes of maternal and neonatal morbidity and mortality, because sometimes we have to deliver people very, very early, and the babies don't make it because they're so early. It disproportionately affects people of color. Some of the risk factors are chronic medical conditions, for instance, like lupus or diabetes or just chronic hypertension. So that means, high blood pressure outside of pregnancy, advanced maternal age, young age. So basically everybody on both ends of the spectrum, first pregnancy, autoimmune disorders like lupus. And then how do you prevent it? How do you prevent it? You want to optimize the person's health before they get pregnant. And so that's the reason why I was talking about back on the annual exam is, what's your nutrition like? What's your exercise like? Because your goal is to optimize their health, get their weight where you want it to be, get their blood pressure to where you want it to be, make sure they have good birth control so that we can get them there. And then if someone has it in a previous pregnancy or they have some of the risk factors, you'll go ahead and put them on a baby aspirin, because baby aspirin, the 81 milligram tablet, has been shown to decrease the risk of preeclampsia. Of course, you're supposed to start at 12 weeks, but let me tell you, when I see a patient for the first time, I go ahead and start them because it is no problem with starting them earlier. For the person that has preeclampsia, they do have a future risk of heart disease and preeclampsia in future pregnancies. So I'll allow you all to ask any questions. Feel free to reach out to me. I have a lot of people reach out to me on social media. That's my Instagram, Jaylene Sims 01. And then on Facebook, I'm J Sims. It's probably easier to find me on Instagram, but that's it. We're gonna go see the hospital in just a minute, but I wanted to see if y'all have any questions first.
Yeah, we can definitely ask a few questions. So our first is, you mentioned preeclampsia. It's something that, like you mentioned, you see a lot being an OB. A student asked about what mechanism behind that causes the symptoms that you see.
So preeclampsia is a vasoconstrictive disorder. And as a result, people start to third space. As they third space, as they're third spacing, there's vascular damage. And so, of course, there's vasculature in every area of the body, the liver, the lungs, the kidneys, and depending on how significant it is, you start to third space to the point where you can have pulmonary edema, where you can have kidney damage, where you have your edema in your hands, your eyes, everywhere, because the vascular just kind of collapses down and everything comes out. And so that's the reason why people get really edematous. There is still a lot of research going on, but the main thing is that it's an issue with the placenta. There's different like proteins and things that code for just a bad placenta and causes this like early on, and then it manifests later. And so that's the reason why we tell people to take the baby aspirin early on, so that we can try to prevent the oxidative stress that happens on the placenta and leads to preeclampsia later.
So what kind of specialties, just day to day, do you usually and commonly work with?
So every single day, for the most part, I work with maternal fetal medicine because I have a lot of OB patients, and I just happen to be in an area where I take care of a lot of high risk patients. So as a result, I refer to them a lot, and even a patient that's not having issues, if they're considered a high risk pregnancy, I at least refer to them for them to just meet and have a consult with the maternal fetal medicine specialist. So that's almost every day. Depending on the issue, like for instance, I have a hysterectomy coming up, and the patient also has stress urinary incontinence. And general OBGYNs can actually do slings for urinary incontinence, but because we have a pelvic floor specialist at our hospital, I just let him do them. And so any and every day. I mean, it just depends on the day and what's going on and who needs what. I'll consult all of my subspecialists. Oh, I'm so sorry, y'all. I forgot to mention reproductive endocrinology. They are very, very near and dear to my heart because I use them myself to get pregnant with my 3-year-old. But they also have a 3-year fellowship, and they specialize in helping people become pregnant who are infertile or who just want to get pregnant a lot faster. And so, or who do IVF and things like that. And so I refer to them a lot too. GYN oncology, I refer to them all the time because I diagnose cancer often. And so, or if it's like a really difficult case, sometimes I'll refer to them. And so, yep.
Sounds like a lot of subspecialties going on. And speaking of the subspecialties, it seems like there are some specifically for surgical, more heavy surgical purposes, and others for more clinical medicine. Can you talk through which is which?
Yes. So the minimally invasive surgery fellowship, that is when the person becomes basically a gynecologist. They don't typically do OB after that. So I'm a generalist, and so I do OB and GYN. So I'll do, full spectrum on both of those ends. But then when you become a minimally invasive surgeon, then that person is in clinic seeing GYN patients, maybe people that just have fibroids or endometriosis or pelvic pain or whatever, and then they operate. And so they may operate a lot more than I do because they have a lot more patients that are just GYN and, that need that service. And so they go to their fellowships and they learn more about robotics and laparoscopic surgery and stuff like that. The person that's mainly in clinic, you can actually decide after you've gone through your OB and GYN, or after you've gone through your residency, that you just want to do, you want to be a generalist, but you just want to do clinic and you don't go to the hospital for like your deliveries and stuff like that. You can do that. So basically you would actually, you see your OB patients and all of that, and then you would just refer to someone else so that they can get established and kind of get to know the patient, or the provider who's going to deliver them. Or you can say, okay, well, I just practice in the clinic, so when you go to the hospital for your delivery, then my partners will take care of you. You can take care of them all the way to the end. And so that would kind of be more of the clinic setting. Now, a maternal fetal medicine specialist, a lot of times they'll just be, there's some people that just do consults. So they don't do hospital work, they don't do deliveries, they just do the clinic setting, and then they send them back to their general OBGYN. And so those are some of the people that are just only in the clinic or only in the operating room, or do one versus the other.
And just in general with this specialty, it's a pretty special time, like you said, introducing life into the world. So when you walk through the doors and just meet a new patient for the first time, how do you establish rapport? What's the bedside manner like?
For me, I get in their business a little bit, and I've never had a patient become offended. But my first time meeting a patient, this is how I walk into the room. Hi, I'm Dr. Sims. I'm extra, I'm dramatic, I know, whatever. Nice to see you and nice to meet you. I'll be taking care of you for your pregnancy. And then I'm like, who's gonna be taking care of, who's gonna be helping you through this pregnancy? Who's the dad? Where is he? What's he doing? What do you do every day? Like I literally start to get in their business, and I write a lot of social notes. So when I see the patient back the next time, I'm like, oh, so what happened with so-and-so? Like what ended up happening? So it's almost like we're like gossiping, because, they may tell me like they business. And so I'll come back and ask. And so I feel like that's how I establish a good rapport with patients, because it lets them know that I'm concerned about them. I want them to have support. I'll offer them resources, and that lets them know that I really genuinely care for them. And just throughout the entire pregnancy, when I walk into the room, my first question is, what's going on? What you been doing? Anything you want to tell me? Anything you're concerned about? If I walk into the room and I'm just like right at like, oh, straight to business and stuff like that, well, sometimes I do, but I still ask the other questions too. It makes the visit seem a lot faster, and it makes them feel like they did not get to have a voice. But if I ask them those questions from the beginning, even if they have nothing to say and I only took 5 minutes in that room, they had an opportunity. And that's what they appreciate. And that also helps with the rapport.
It's not every physician that would involve themselves in something like wellness, diversity, equity, inclusion, like we mentioned earlier. What does that work look like? Do you involve yourself day to day? Is it a more weekly thing?
So as the program director for that, we actually have changed our curriculum up a little bit. And so we actually have diversity weeks, and then we have wellness weeks. During the wellness weeks, it's like a 2-week time period where I have like a couple wellness leaders in the residency program, where we like have a full 2 weeks full of activities. Like I'll send somebody to the hospital to give the residents massages. We'll do team building exercises. We'll do presentations related to wellness and like well-being and like dealing with difficult situations. Last year I had a person come and talk to the residents about just financial success. We did a career session where we did resume building, and I reviewed whoever's resume that they sent to me. And so to me, it's about looking at the total picture. We also gave the residents a half day off during that time period. Really, we had to extend it out because we have too many residents to do it in 2 months, because I was like, look, y'all need to go to y'all doctor visits. I don't care if it's an eye appointment. I don't care if it's a wellness visit, whatever it is, y'all need to go to these. And so y'all gonna get this half day off. We're gonna schedule it ahead of time so you can go ahead and schedule your appointments. And then if they were like already up on their eye exams or their whatever visits, dental exams, then I was like, well, go to get a massage, go do something, go take a nap, like do something away from the hospital or away from the clinic. And so that's what that looks like. And then throughout the year, because I don't want it to be like we focused on y'all once and that was it. They do have a resident retreat, and we do journal clubs and things like that. And we try to just come up with things throughout the year that will just make their lives a little easier as residents, because life is not easy as a resident. From the diversity, equity, and inclusion standpoint, we do have a DEI committee too. And on that committee, we meet monthly and we just come up with things that can help us take better care of our patients. We have grand rounds where we have people come and talk to us about different topics. During our diversity weeks, we do multiple presentations about it. When it's time for interviewing, we talk about, we actually have people take surveys so that they can like understand what their biases are, and they can try to like sweep them under the rug so that you can really understand and learn the applicants for who they are, opposed to like what your implicit bias is. And so it's work all year round, and it's hard to really quantify it.
Talked about getting kind of close and personal with establishing rapport with patients, but sometimes it's not always good news. Sometimes there's the death of the baby and all. So when that time does come around, how do you approach presenting that bad news?
That's the worst part of my job, actually. And I have had to tell people that their babies have passed. It's a really sad time. And I just, you have to be direct with patients. You can't beat around the bush. And so I just kind of directly tell them. And I pause for a while to let them process what they just heard. And I try to get them out of the ultrasound position so that we can sit up and talk face to face. I ask them if they have somebody like around that can come back with them so that we can like, that person can have a support person and answer questions. And for instance, when people have lost a baby, there's multiple ways that it can happen. It can be as an early miscarriage, and it can be a baby that can live. I had a person that lost her baby at 35 weeks. That's a baby that can like literally deliver and go home with her, not even have to stay in the NICU at that gestational age. And it's really, really hard. So offering support, offering counseling services, offering a listening ear, being quiet and letting them just process and speak if they want to, or not say a word. All of that is still considered, support for the patient. After, we've gone through all of that, then, you have to get back to business. Okay, so this is what's next. And then of course, for those miscarriages, you have to make sure that patients know it's, all of them, it's not their fault. There are sometimes where patients have done cocaine, or they've had tobacco use and things like that, or they've had like a fight or something where that could have been the cause of it. And actually recently there was a person that had a previous death from using cocaine, and then she turned around and did it again, and her baby died again. And in those circumstances, it's almost like, oh my gosh, like we can't get you to stop using, but you still want to be supportive and respectful of the patient. And so that's where that diversity, equity, and inclusion piece comes in. This is a patient that's different from us, because it's like, we wouldn't do that, or you would think that you wouldn't do that, but you have to really put yourself to the side and understand where the patient is and try to help her through the situation.
Yeah, it definitely is a tough conversation when it does come around.
Mm-hmm.
So sometimes there might be the case of, if it's difficult for a patient to, go home, usually we hear patients just having regular check-ins and visits like you mentioned, but are there cases where it's too difficult or too dangerous, I guess I would say, for them to go home unmonitored? Do they have to stay inpatient for the majority of their pregnancy? Is that ever the case?
Oh yeah, all the time. We have patients up there right now like that. Pre-eclampsia, if someone has pre-eclampsia early and before 34 weeks and they're stable, they actually stay in-house for the rest of pregnancy. I don't care if they get diagnosed at 23 weeks. You stay in-house for 11 weeks until time for delivery. And we monitor blood pressures all, 4 times a day or 6 times a day, something like that. We monitor the baby. We monitor labs, all of that. There
Yeah.
are some types of twin pregnancies where you have to get monitored that way. And so, yeah, there are conditions like that. There have been some cases where a patient was stable enough to be at home, but we wanted them near, like say they live far away, because we're the tertiary care center, meaning we're the place that everybody refers to. And so we've allowed them to stay nearby at a hotel that we were able to establish a relationship with. So they could come back to the hospital pretty much every day for like their fetal testing and stuff.
Yeah, that sounds good. When it also might come around for, let's say, a mother to code, do you have, what are the process in place, the protocols in place when you have to do an emergency delivery on the bedside?
You want to basically have the C-section started within 5 minutes of chest compressions. And basically you cut her right there. You have to have anesthesia and everybody there. And at our hospital, we have everybody in house 24 hours a day. And so there is actually, if we call it, there's actually a number that we can call, and it sends out a stat page to the NICU, all the nurses, all the doctors carrying a particular pager. It goes to the anesthesia. And basically you type in 000-911 and everybody comes running. You don't know where you're going. Most of the time, everybody just meets in the operating room and whoever's taking care of the patient brings the patient there. But if it's a bedside, everybody comes to labor and delivery and we'll tell them room 212 or wherever. And then everybody's kind of like right there. And so, and if that happens, we do the delivery right there, pass the baby off. And then we close back up to our best ability, like close the uterus. And sometimes we won't close the abdomen all the way if the patient is completely unstable, and we'll get them off to the ICU.
Once they do deliver, in terms of postpartum checks, what do those look like?
So in the hospital, it's routine blood pressure watching, just vitals throughout the day and night. And then each morning we round on the patients. The nurses, they take care of the patients and they kind of round every once in a while too. But as the physician staff, we round at least 1 time a day. And then, people say a 6-week checkup. We don't do 6 weeks anymore because a lot of times by the time you get to 6 weeks, everything bad then already happened. So you want to check on them earlier. So I do 3 to 4 weeks now. And our governing body, which is called the American Colleges of Obstetricians and Gynecologists, they actually have recommended that we do them early too.
All right. Well, one more question. I guess we can look around to check out the hospital. A student asks, in terms of, you mentioned OB, and it's OB-GYN, so it's 2 parts, right? Obstetrics and gynecology. Are there residencies where it's just gynecology or just obstetrics, or is it always both?
It's always both right now. However, there have been some discussions of doing one or the other. Give me just a minute. I have a resident calling me. Hey, what's up? So we're doing 201 first. When is she gonna be ready? Is her lab's already back? Oh, sweet Lord. Okay. Okay. So, okay, hold on. Let's think about this though. Okay. So, do you have to cut somebody who's got choreo? Okay. Okay, so you're cutting her for a non-reassuring fetal heart rate tracing. Okay. Because what I'm seeing right now on 15 is she looks okay. I saw that one right there at the end of it. I see that detail. Okay. Well, I just want to make sure because you don't have to cut somebody because they have choreo, but you have to have another reason. Okay. All right. Okay, we'll see how she does. So, okay, so she has a fever or a temperature of 100.3, and she's been rising. So, are y'all gonna call her choreo based on a not fever yet? And what else? What are your criteria? Okay, okay. I'm fine with antibiotics, but I just want y'all to be able to document it. Because you got to have two of the two. Yeah. Okay. All right, sounds good. Thank you. So at a teaching hospital, you have to challenge them. And so that's what I was just doing there. All right, sorry, what was the last question?
Well, we do have a few other questions, but just for the sake of time, if you want to just show us around.
Yeah, I'm logging in right now on my cell phone, and I'm gonna leave from my computer.
All right, sounds good.
All right, let's see. Am I okay? I'm off mute. All right, y'all can hear me?
Yep, perfect.
Okay. All right, y'all. So when I'm in the staff lounge, this is what I can see. I can see all the babies on the monitor. And so that's why I was saying, well, what I'm seeing right now is the baby looks fine. Because let me tell you, these residents sometimes are quick to cut somebody. And I'll be like, heck no, let's give her a chance. And so, anyways, that's what I'm okay. See, now the baby want to do another decel. Just a second. I always gotta have these sheets with me. All right. We're gonna go out onto labor and delivery. At our hospital, we wear masks, mainly in the area where patient care takes place. And so we don't have to wear them in our lounges or in other places. So let's go to the operating room first. This is where we're going to be going in just a few minutes. I'm going to turn my camera around. Oh. All right. In the operating room, you actually can't go in without a hat on. Y'all see my hair is free, so let me just put my phone down for just a second to put on a scrub cap. Sorry, now y'all looking at a box.
It's no problem at all.
Okay, here we go. All right, y'all. This is OR. They all look like this. We have 5 operating rooms on our labor and delivery unit. And 2 of them are specific to OB, and 3 of them are GYN. I'll show you all our robot room. This is the room we just came from. Is a GYN room. This room right here this is where they do all the robotic surgeries. There's the robot. And then there's one of the monitors where we can see everything up there. There's another monitor there where we can see, and then there's loudspeakers where the person that sits at these consoles, one is a teaching one is the actual surgeon one, but you can both operate at those. So say for instance, the learner is not getting something right, then the person can actually step in and kind of help like the surgeon can. And so if the person is sitting here in this console and needs to speak, because everybody's kind of far from each other, they can speak and it'll come over the loud system so everybody can hear what the surgeon is saying. So that's what's cool about the robot. Even though you're not standing right face to face with everyone, you have a way to communicate. This is where they've had sections, or say for instance, we have someone who is really early pregnancy. They can they'll bring the baby back there for resuscitation. Labor and delivery that way, it just looks like a whole bunch of rooms. So we'll go down to women's urgent care. If I happen, because it has go downstairs. So if I happen to drop you all, I'll like get right back on. All right. Are there any questions?
The audio is cutting in and out a bit, but we do have, if you want to go through a few questions, we can definitely go through them. One question we did have was about how COVID had affected the overall specialty.
Sorry, it cut out a little bit, but now I'm in an area where I can probably hear a little bit better.
No
did
problem.
You read the question?
Yeah. So a student asked, how has COVID affected the overall specialty? It's a broad question, but they were just curious about how that process has been.
It's a great question, actually. Because patients who are pregnant are high risk. You know, even for like the flu, patients who are pregnant, because their immune systems are just a tad bit compromised in order to like maintain the pregnancy, which is like a foreign body. We've had some very, very sick COVID patients, and a lot of our bedsides, C-sections more recently have been because of like some of those patients have gotten so sick that we didn't have time to get them to the operating room. And so it's definitely affected us from that standpoint. Initially, our patients could not have a person with them when they came to the operating room because we didn't have enough supplies to give them like a hat and a gown to be in the operating room. And then now our visitor policy changed. I mean, there's so many things, like patients don't have as much support as they used to be able to have. Now we finally gotten to the point where people can have two people, patients can have two people in the room with them. But for a while, there were one person in the room with them on labor and delivery only. So if they went up to like the postpartum or antepartum floor, they were in the hospital by themselves. During that time, I actually had a patient that was in the hospital for several weeks. Can you imagine having to sit in the hospital with no support for weeks? That's like a horror story. So definitely from the OB side, it affected us. From the GYN side, we had to cancel lots of surgeries that were definitely needed. And the ones, when they got back to the point where we could do surgeries, they were like, y'all can only do outpatient surgeries. And then when we could do, if we were going to do an inpatient surgery, we had to justify why the person was having an inpatient surgery, meaning like if someone needed an open hysterectomy, and say the person had like a really large uterus due to fibroids, for a while we couldn't do those. And so the person would just bleed and bleed and bleed. And once we got to the point where the patient was really bad off, we had to justify it and go ahead and do those surgeries. And so it affected us in patients from that standpoint too, because we didn't operate for a while. And then as far as them in the post-operative state, they couldn't have a person in the room with them. So they had to rely on the nurses to help get them up when they needed to go, to the bathroom even. So just kind of thinking about what types of things that patients would want while they're in a foreign place, they didn't have that on GYN or OB. And so it was a really trying time. And now we're getting back to a better place. And so things are kind of back in gear.
Another student asks about specifically robotic surgery. You mentioned it's something that is becoming increasingly used, and that's included in training, definitely. So for what specific operations do you resort to robotic surgery for?
Hysterectomies can be done robotically. Removal of like pelvic mass. You can do myomectomies, removing fibroids laparoscopically. Most of the time people try to reserve robots for more of major surgeries. Like you're not going to tie somebody's tube with a robot. Like that's just a waste of resources and money. But if it's a hysterectomy, you can do it. Patients that I think would benefit from, sorry, that dang door is just loud. patients that I feel like would benefit from a robotic surgery are ones that have a large abdomen but a small uterus, and it makes it a lot easier for the robot to have to be the one to like hold the instruments, where your body, like, it's really taxing on your body to do surgeries on patients that are like obese. And so the robot comes in handy a lot during for those patients.
Also, mid-level providers, they're involved in the field. So what are they able and not able to do?
So like at my job, we have a couple of nurse practitioners, and they see OB and GYN patients in the clinic. And after they get them to a certain area, like in the pregnancy, they'll like refer them to like one of the providers that deliver. From the GYN standpoint, they'll do like some of them don't do ultrasounds, but the ones that do, they'll do ultrasounds, they'll do endometrial biopsies, they'll do birth control visits, they'll do annual exam visits. And once it gets to a point where they're like, well, this is a little bit more than what I do, then they'll refer over. So they do a lot, actually, and they're very helpful.
For rural areas where there's not necessarily an OB around, is it possible that an internist or family practitioner is able to deliver?
Family practitioners actually do deliver. They take rotations where they do OB, and in certain areas, they even do C-sections. So yes, internists, not necessarily, because they don't actually do OB as a field. I'm gonna turn my camera around. This is our women's urgent care setting. So this is a emergency room just for women, OB or GYN patients. So we have several rooms, 8 regular rooms, and then 1 exam room. This is like our little workstation here. The residents will be back in a second. I'm gonna let y'all let them say hi to y'all if we're still on and they come back. But this is at a lot of hospitals. The emergency room is one that's 20 weeks and lower, and all GYN patients, and the triage on labor and delivery if they're 20 weeks and up. At our hospital, we see everything from 2 seconds pregnant all the way to term. And then we see all of the GYN patients. Like if they have a GYN complaint now, if they come over here talking about chest pain, we'd be like, you gotta go next door. If they're not pregnant.
And I guess we can end it off with one more question. So generally people know that 40 weeks is usually, that's the time that most patients.
No, go ahead.
I didn't want to see the tall doctor, didn't want to see the chest X-ray.
Oh, hold on. Let me find him real quick.
I can send it through.
Yeah, if you will send it through, but let me just take a look. I'm sorry. Okay. I don't know if it's like hazy, like infiltrates or anything like that, but overall, okay. All right. Thank you. Yeah, you just send it through. We'll just take a look at it. Okay. Thank you. That was a chest X-ray that we had gotten on a patient. All right. Sorry. What was that question?
Yeah. So I was just quickly asking. Generally, people know 40 weeks is usually the time that a patient delivers, but it sounds like sometimes it's 37, 38, 39. Can you break down what's the best case scenario, or what are suboptimal scenarios in terms of weeks of delivering?
39 weeks minimum for like labor. Anything or obstetric indication. Colleges of obstetricians and gynecology.
I think the audio is cutting out a bit. Just give us a moment. She'll join back in.
Sorry.
No worries. No worries.
So I was saying it's 39 weeks is the minimum in order for it to be like for an elective delivery. Some insurance pay if you deliver someone before that without a medical or an obstetrical indication. So from there, say for instance, for 38 weeks, sometimes we'll do that for someone who has chronic hypertension and they're on like meds. 37 weeks, we'll do that for someone who has what we call gestational high blood pressure, meaning high blood pressure in pregnancy without all of the severe stuff. And then for 34 weeks, that'll be like a severe pre-eclampsia person, or for someone whose bag of water is broken. We'll do 38 weeks also for someone who has twins. Certain types of twins get delivered earlier. And so it just depends on the medical or the obstetrical issue that would cause for us to deliver early. But the time of delivery for anyone who is uncomplicated or who's having an elective induction is 39 weeks or higher.
All right. Well, I guess since we're at the end of the hour, that wraps today's session up. That was a great session. It was actually the first that we saw physician on call. So it was really exciting to see that. And thank you again so much for presenting the specialty. It was really exciting to see. For our shadowers, to earn your certificate, to credit your attendance, you must pass the quiz that we've now posted in the chat box. It's also available on our website under the virtual shadowing page. If you scroll a bit down, you'll see shadowing quiz, Dr. Sims, and click onto that. Answer the 10 questions, and if you get 60% or higher, you will pass and receive a certificate. That certificate will be sent over to the inbox of the email address you list on the quiz, and it's going to be due next week at 11:59 Central Standard Time. It's going to be on Friday, July 22nd, so keep that in mind. If you don't receive your certificate, if it doesn't go through, please check your spam folder, and if not, feel free to contact us. Our next virtual shadowing session is going to be with Dr. Hobbs this Monday, July 18th, at the same time as usual, 7 p.m. Central. And again, for those who want to stay tuned with us, follow us on Instagram or subscribe to our listserv. Either way works. But outside of that, again, thank you so much, Dr. Sims. For those who want to follow you up on Instagram, your socials, do you want to plug them in?
Sure. It's Jaleen, Jaleen, Sims, SIMS1. That's my Instagram. So Jaleen Sims 01. And then on Facebook, I am J Sims.
Sounds good. All right. Well, thank you so much again, and hope everyone has a great